purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and
Welcome to the podcast series, The New Student Pharmacist, where we discuss chemistry and pharmacy, as well as leaders in pharmacy careers, community, and chemistry and pharmacy research. We encourage you to support the work we are doing and follow us on Spotify and Apple Podcasts by subscribing for free. Note, the views on the podcast represent those of my guest and I.
Okay, so fluids and electrolytes: water, sodium, calcium, phosphorus, potassium, and magnesium. Note, this recording was adapted from the work of Dr. Muhammad, Professor I had at Howard. So some objectives: we want to discuss the normal fluid and electrolyte distribution into the body's intracellular and extracellular compartments. We want to calculate and interpret plasma osmolarity based on serum, sodium, glucose, and BUN. You want to describe the role of arginine for vasopressin in maintaining plasma osmolality. We want to discuss the potential causes of hyponatremia, hypernatremia, hypokalemia, hyperkalemia. Hypomagnesemia, hypermagnesemia, hypocalcemia, hypercalcemia, hypophosphatemia, hyperphosphatemia. Also want to be able to list the common signs and symptoms of hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypomagnesemia, hypermagnesemia, hypocalcemia, hypercalcemia, hypophosphatemia, hyperphosphatemia. You want to be able to formulate pharmacologic plans for patients with clinically significant hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypomagnesemia, hypermagnesemia, hypocalcemia, hypercalcemia, hypophosphatemia, and hyperphosphatemia. The total body water comprises 45 to 80% of body weight, depending on sex and age. Total body water is distributed primarily into two compartments: intracellular fluid, ICF, and extracellular fluid, ECF. ECF is intravascular fluid, plasma/serum, and cellular ECF is intravascular fluid, plasma, serum, or interstitial fluid. Total body water is 0.5 to 0.6 liters per kilogram. Intracellular fluid, 2/3 of total body water. Extracellular fluid, 1/3 of total body water. Intravascular fluid is 1/4 of extracellular fluid, and interstitial fluid is 3/4 of extracellular fluid. Separated intravascular and interstitial are separated by capillary membranes. Overview of fluid balance. Fluid distribution between intracellular and extracellular spaces is determined by osmotic pressure. Effective osmoles are solutes that cannot freely cross cell membranes and determine osmotic pressure. ECR, sodium holds water in the extracellular space. Chloride, proteins, glucose, medications. ICR, potassium holds water within the cells. Proteins. And the activity of cellular sodium-potassium ATPase pump allows for maintenance of solute compositions in ECF and ICF and regulation of cell volume. So types of IV fluids. You have crystalloids, solutions of ions that can cross the semi-permeable capillary membrane. Examples of 0.9% sodium chloride, otherwise known as normal saline, activated ringer, dextrose 5% water, D5W. Also have colloid suspensions of molecules that cannot cross semi-permeable capillary membrane due to the molecular weight of the molecules. They remain in the intravascular space longer, may seem better than crystalloids based on distribution properties. No evidence to demonstrate improved outcomes. These are higher costs. Examples include aluminum, heterstarch, and dextrin. Distribution of IV fluids. So crystalloids, you have your normal saline or lactated ringer. Sodium and chloride do not freely enter cells but evenly distribute in extracellular space. Each liter provides 250 ml into intravascular space. D5W, dextrose is metabolized to H2O and CO2. Water crosses any membrane. Each liter provides 100 ml into intravascular space. Colloid is too large to cross capillary membrane. Albumin 5%, 100 ml. Infused provides 100 ml intravascular volume replacement. So, quick snapshot in terms of tonicity. Dextrose 5% in water is hypotonic. 0.45% normal saline. Hypotonic. Activated ringer is isotonic. 0.9% NaCl on normal saline is isotonic. And 3% NaCl is hypertonic. Fluid resuscitation. Intravascular fluid depletion is common due to hypovolemic or septic shock. The prompt intravascular fluid replacement. Goal is to restore intravascular volume and prevent organ hypoperfusion. Normal saline or lactated ringer are recommended. Crystalloids preferred due to the decreased cost and no proven clinical benefit of colloids. Chloride-rich versus chloride-poor solutions. Hyperchloremic, metabolic, acidosis. BA is a 54-year-old male presenting in the emergency department with hypotension, 88/58 millimeters mercury, tachycardia, heart rate of 110 beats per minute, glucocytosis 18.6 times 10 to the 3 per microliter, fever 101.6 degrees Fahrenheit. Blood cultures times 2 balls are set for gram-negative, are positive for gram-negative rods. The emergency department physician asks you to select the liter of fluid for fluid resuscitation. Which one of the following fluids is the most appropriate for BA? The answer is normal saline. Osmolality is a measure of the osmoles of solute per kilogram of solvent, milliosmoles per kilogram, where osmolarity is a measure of osmoles of solute per liter solution, milliosmoles per liter. So serum osmolality can be measured by a formula that goes as such: 2 times the sodium amount plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. So in brackets 2 times Na plus glucose divided by 18 in brackets plus B1 over 2.8. Serum osmolality. Normal serum osmolality 275 to 200 milliosmoles per kilogram. Sodium is the primary determinant of serum osmolality. Major changes in serum sodium can result in changes in serum osmolality. Changes in serum osmolality cause fluid shifts across cell membranes. Increased serum osmolality causes cellular dehydration. Decreased serum osmolality causes cellular swelling. Isotonic IV fluid, normal saline, no osmotic gradient, no fluid shift. Hypertonic IV fluid, 3% normal, 3% NaCl solution, cell dehydration / shrinkage. Hypotonic IV fluid, 0.45% NaCl, RBC swelling, hemolysis, brain cell swelling, cerebral edema, herniation. Fluid homeostasis, arginine, vasopressin, ABP, as antidiuretic hormone. ABP results in water absorption, stimulates thirst, triggers the renal tubules to absorb water in distal and plantar tubules. ABP release is stimulated by increased blood osmolality, decreased blood volume, decreased blood pressure, increased stress. Low plasma osmolality triggers a negative feedback that leads to less ABP release. So increased water intake, response to thirst, plus decreased water excretion. Kidneys response to arginine vasopressin equals decreased serum osmolality. Assessing fluid status, signs and symptoms. For hypovolemia, we are looking for tachycardia, hypotension, decreased urine output, increased ratio of blood urea nitrogen to serum creatinine. We're looking for dry skin, dry mucous membranes, and weight loss. For hypervolemia, we're looking for jugular venous distension, weight gain, edema, decreased hemoglobin to hematocrit, decreased hemoglobin over hematocrit, so the quotient is decreased, and dilutional. Also looking for hypertension. Disorders of sodium balance, hyponatremia and hypernatremia. The normal serum range is 135 to 147 milliequivalents per liter. Major extracellular cation, primary determinant of plasma osmolality and major osmotically active solute. Serum concentration tightly regulated so that serum osmolality can remain constant. Disorders in sodium homeostasis are related to total body water disturbances. Must take volume status into consideration. Hyponatremia and hypernatremia are common disorders in hospitalized patients. So hyponatremia, sodium is less than 135 milliequivalents per liter. Most common electrolyte abnormality in both adults and sodium. Drug-induced hyponatremia is common. People on thiazide diuretics and also on psychotropic medications. Significant morbidity / mortality, transient or permanent brain dysfunction, acute effects of hypoosmolality or too rapid correction of hypoosmolality. Hyponatremia evaluation. Determined type by serum osmolality. Normal, is approximately 280 milliosmoles. Isotonic hyponatremia. So pseudo-hyponatremia. High is greater than 280 milliosmoles. As hypertonic hyponatremia, usually due to hyperglycemia or other osmotically active substance. Low is greater than 280 milliosmoles. Hypotonic hyponatremia. Most common cause of hyponatremia, true hyponatremia. further characterized by ECF volume status or extracellular fluid volume status, hypovolemia, euvolemia, or hypervolemia. Isotonic hyponatremia. Okay, so we're now talking about further characterized by ECF volume status, hypovolemia, euvolemia, or hypervolemia. Isotonic hyponatremia. Elevated serum lipids and proteins result in the movement of water from the ICF to the ECF to restore osmotic balance. Dilution of sodium in the sample lowers sodium concentration, no deficiency in total body stores. False hyponatremia. Artifact of method of some sodium cation measurement. Uncommon today with no methods of measurement. Total body water and sodium are unchanged. Hypertonic hyponatremia. Increased serum osmolality due to presence of excess non-sodium effective osmoles in the ECF. For example, mannitol or sorbitol. Commonly encountered in patients with significant hyperglycemia. Elevated glucose provides effect plasma osmoles. Fusion of water from ICF into the ECF. Expansion of ECF volume and decrease in sodium serum concentrations. For every 100 mg per deciliter increase in glucose, serum sodium decreases by 1.6 milliequivalents per liter. Corrected serum sodium equals measured sodium plus 0.016 times serum glucose minus 100, where serum glucose minus 100 is the brackets. Total body water and sodium cation are unchanged. Hypotonic hyponatremia, most common and has many potential causes. Assess the ECF volume in 3 categories. Decreased ECF volume, hypovolemic, normal ECF volume, euvolemic, increased ECF volume, hypervolemic. Appropriate treatment depends on accurately identifying cause. So characteristics of hypotonic hyponatremic states. So characteristics we'll be discussing will be water and sodium, the causes, effect on total body water, effect on total body sodium, clinical presentation, and treatment. So for hypovolemic hyponatremia, sodium loss is much greater than water loss. Causes involve renal, so thiazide diuretics, and non-renal diarrhea, cerebral salt wasting. It results in a decrease or reduction in reductive or decreased effect on total body water, with decreases on total body sodium. The clinical presentation shows up as orthostasis, hypotension, tachycardia, dry mucous membranes, and CNS changes. Treatment involves normal saline until vital signs are stable, maintenance fluids to continue, fluid deficit replacement, sodium replacement of cerebral salt wasting, and VRAs are contraindicated. So for euvolemic, isovolemic hyponatremia, water gain only is caused to be syndrome of inappropriate antidiuretic hormones, so SIADH, polydipsia, very thirsty, and excess free water intake. Those are some of the causes. Effect on total body water, increase. Effect on total body sodium. Looks like it's equilibrium. Depends on severity. The clinical presentation depends on severity of hyponatremia. It can present as seizures or lethargy. The treatment involves water restriction, methoxycline, loop diuretics, and vacuums. Okay, so for hypervolemic hyponatremia, water gain is greater than sodium gain. Causes can be heart failure, liver cirrhosis, kidney failure, nephrotic syndrome. Effect on total body water, increase. Effect on total body sodium, increase. Clinical presentation, peripheral and pulmonary edema, variable blood pressure, treatment, sodium restriction, water restriction, loop diuretics, vacuums. So hypovolemic, so that's referring to the ECF. Hypotonic is referring to the serum of molarity, and hyponatremia is referring to the iron concentrations. Hypovolemic, you have decrease in your volume of ECF. Hypotonic, you have less than 280 milliosmoles. Hyponatremia, you have less than 135 milliequivalents per liter. So this occurs due to fluid loss. Patients with fluid loss may become transiently hypernatremic, may be caused by diarrhea, excessive sweating, and diuretics. Total body water and sodium are decreased. Transient hypertonic state leads to osmotic ABP, so oxygen vasopressin release, burst response. The patient drinks water, hypotonic or given IV hypotonic fluids, water retention, and hyponatremia. So euvolemic, so we have the correct, a good normal volume, ECF. Euvolemic, hypotonic, so the serum osmolarity is still less than 280 milliosmoles. Hyponatremia is less. Hyponatremia serum sodium iron concentration is less than 135 milliequivalents per liter. Normal or slightly decreased ECF sodium content and increased total body water ECF volume, so water intake greater than output. Volume increase is typically not significant enough to cause edema or signs of volume overload. Patient looks euvolemic. Most commonly caused by syndrome of inappropriate antidiuretic hormone, SIADH. So syndrome of inappropriate antidiuretic hormone, water intake exceeds renal excretion due to increased non-osmotic release of AVP or enhanced renal sensitivity to AVP. Most common causes of SIADH: tumors, CNS disorders, pulmonary disease, drugs. Examples include carbamazepine, lamotrigine, cyclophosphamide, SSRIs, TCAs, and ecstasy. Hypervolemic hypotonic hypernatremia occurs in conditions where both sodium and water excretion are impaired: cirrhosis, heart failure, nephrotic syndrome. Expanded ECF volume and edema, decreased effective circulating volume, resulting in renal sodium retention and ECF volume expansion and edema. Concomitant non-osmotic AVP stimulation and water retention in excess of sodium retention. Total body water and sodium are increased. Hyponatremia signs and symptoms. Primarily neurologic in nature. Presence and severity of symptoms depend on rate of onset and magnitude of abnormality. So let's look. Mild, moderate, and severe. So mild, 125 to 134. Mild hyponatremia, 125 to 134 milliequivalents per liter. Mild hyponatremia, 125 to 134 milliequivalents per liter. Symptoms often asymptomatic, associated with impairment of attention, posture, gait, increased fall risk, nausea, and malaise. Mild hyponatremia, 125 to 134 milliequivalents per liter for serum sodium. Symptoms often asymptomatic, associated with impairment of attention, posture, gait, increased increased fall risk, nausea and malaise. Moderate hyponatremia, 115, 115 to 124 milliequivalents per liter. Presents as with symptoms of headache, lethargy, restlessness, altered mental status, and disorientation. Moderate hyponatremia, 115 to 124 milliequivalents per liter. Headache, lethargy, restlessness, altered mental status, disorientation. So severe hyponatremia. Severe hyponatremia, 110 to 114 milliequivalents per liter. Severe 110 to 114, moderate 115 to 124, mild 125 to 134. Severe is in the range from 110 to 114, moderate 125 to 124, mild 125 to 134. So for severe hyponatremia, you have symptoms of seizures, coma, respiratory arrest, brainstem herniation, or death. Hyponatremia treatment goals. Treat hyponatremia treatment goals. Treat underlying cause of sodium cation, volume imbalance. Correct hyponatremia safely. No more than 6 to 12 milliequivalents per liter in 24 hours. Hyponatremia general treatment approach. Treatment plan will depend on underlying cause and severity of symptoms. The initial treatment goal is to control severe symptoms. Appropriately balance the risk of hyponatremia versus the risk of osmotic demyelination syndrome. To appropriately balance the risk hyponatremia versus the risk of osmotic demyelination syndrome. Osmotic demyelination syndrome, ODS, can occur with rapid correction of hyponatremia, acute decrease in brain cell volume. ODS, acute decrease in brain cell volume based on ODS, is paralysis. Patients with ODS may develop hyperreflexia, para/quadriparesis, Parkinsonism, pseudobulbar palsy, locked-in syndrome, or death in 1 to 7 days. Hyponatremia treatment options: 3% NaCl reserved for severely symptomatic patients, seizures, delirium, coma, regardless of etiology. Normal saline, hypovolemic, hypotonic, hyponatremia. So low volume in ACF, serum osmolarity, less than 280 milliosmoles. Hyponatremia, which you have serum sodium cation concentration that's 135. So mild hyponatremia is 125 to 134. Moderate hyponatremia is 115 to 124. And severe is 110 to 114. Severe present seizures, coma, respiratory arrest, brain herniation, and death. Moderate headache, lethargy, restlessness, altered mental status, orientation. Mild, symptomatic, associated with impairment of attention. So you go from impairment of attention, mild, moderate, you have a headache, lethargy, restlessness, altered mental status, and severe, you have a seizures, coma, respiratory arrest, brain herniation. So fluid restriction, loop diuretic or plus or without loop diuretics, hypovolemic states, hypervolemic, so you know, high volume in the ECF, and that occurs with heart failure or cirrhosis. Euvolemic states when you have syndrome of inappropriate antidiuretic hormone, polydipsia, you're very thirsty. and excess administration of hypotonic IV fluids. Don't quickly correct hyponatremia, because that can cause ODS, osmotic demyelination syndrome. So no more than 6 to 12 milliequivalents per liter in 24 hours. Survaptants, euvolemic hypotonic hyponatremia, SIADH, hypervolemic hypotonic hyponatremia, heart failure. The euvolemic hypotonic hyponatremia, you can use survaptants. For hypervolemic hypotonic hyponatremia, you can use survaptants. So for euvolemic and hypovolemic hypotonic hyponatremia, you can use survaptants. For hypovolemic hypotonic hyponatremia, you use normal saline. For euvolemic and hypervolemic hypotonic hyponatremia, you can use survaptants. For hypovolemic hypotonic hyponatremia, you can use normal saline. Demeclocycline, some patients with SADH is not controlled by water restriction alone. Demeclocycline, pharmacologic category, tetracycline antibiotic, cycline at the end. Mechanism of action: inhibits action of arginine vasopressin in patients with chronic syndrome of inappropriate antidiuretic hormone, SADH. Increases free water excretion. Replacement therapy: SADH patients not adequately controlled by fluid restriction alone. Dosage 300 milligrams per mouth 2 to 4 times daily, and that's off-label. Late onset of action 3 to 6 days. No rule in acute management of severe hyponatremia. We know with severe hyponatremia, you'll have symptoms of seizures, respiratory arrest, brain separation, death, and that's referring to severe hyponatremia is referring to a serum sodium cation concentration of 110 114 milligrams per liter. Vasopressin receptor antagonists, survaptants. Vasopressin receptor antagonists, survaptants. Mechanism of action: excretion of free water without loss of serum electrolytes, resulting in net fluid loss. Increase urine output, decrease urine osmolality, and restoration of serum sodium levels. Indications: hypervolemic or euvolemic hyponatremia. Remember, for hypovolemic, hypotonic, hyponatremia, you can use normal saline as a treatment option. Okay, contraindications: hypovolemic, hyponatremia, anuria, concomitant use with strong CYP3A4 inhibitors. Survaptan, otherwise known as SAMSCA, dosing 50 milligrams per ml daily. After at least 24 hours, you may titrate up to a max 16 milligrams per day. You must start in hospital. Do not use for more than 30 days due to risk of hepatotoxicity. Don't use for more than 30 days due to risk of hepatotoxicity. That's referring to tolvaptan, SAMSCA, and Vaptans are vasopressin receptor antagonists. Vaptans are vasopressin receptor antagonists. They're used for hypervolemic or euvolemic hyponatremia. Conivaptan, Prisol. Dosing is 3 milligrams IV and infused over 30 minutes. That's your loading dose. 20 milligrams IV, infusion over 24 hours. 0.83 milligrams per hour for 2 to 4 days. Do not use for 4 days. Okay, do not use hypertonic saline for chronic asymptomatic hyponatremia or hyponatremia secondary to diabetic ketoacidosis. Glucose is corrected, sodium will as well. Hyponatremia associated with heart failure will be chronic and asymptomatic. So do not use hypertonic saline for chronic asymptomatic hyponatremia. Hyponatremia secondary to diabetic ketoacidosis. Do not use hypertonic saline for hyponatremia secondary to diabetic ketoacidosis. As glucose is corrected, sodium will as well. Do not use hypertonic saline to hyponatremia hypernatremia associated with congestive heart failure, which is chronic and asymptomatic. Jay is a 60-year-old male admitted to the ICU with septic shock, gram-negative bacteremia, and SIADH. Serum sodium steadily decreased from 132 milliequivalents per liter, so he was originally in the mild hyponatremic range, and now it's at 110 milliequivalents per liter, so he's at severe hyponatremia. Past 2 days. He had a seizure today and was administered lorazepam IV. The ICU team determined hyponatremia to be the cause of the seizure. Which of the following is the most appropriate treatment today? So he has severe hyponatremia. Severe hyponatremia. IV 3% sodium chloride, so hypertonic chloride solution. 3% sodium chloride. Which of the following is not contraindication for tolvaptan? Hypokalemia is not a contraindication for tolvaptan. Baptans are vasopressin receptor antagonists. Baptans are vasopressin receptor antagonists. Okay, so let's talk about hypernatremia. Hypernatremia is when sodium is greater than 145 milliequivalents per liter. Always associated with hypertonicity and increase in serum osmolality due to water deficit relative to sodium in extracellular fluid. Often due to impaired thirst response on those who don't have access to water, inability to replete water deficit. Young infants and children mechanically ventilated or comatose, patients, elderly, disabled. High mortality rates. Clinical outcomes depend on how severely rapidly hypernatremia develops. Hypernatremia pathophys most often results from water loss by either renal or extrarenal mechanisms. Most often results from water loss by either renal or extrarenal mechanisms. It can result from hypertonic or isotonic fluid administration or excess sodium ingestion. It can also be caused by diabetes insipidus. Patients excrete large volumes, 3 to 20 liters per day of diluted urine. Central DI, central diabetes insipidus, to decrease RGD vasopressin secretion, or nephrogenic DI, decrease kidney response to RGD vasopressin. Let's talk about hypernatremia. Characteristics we'll be discussing will be water and sodium, the causes of these different types of hypernatremia, effect on total body water, effect on total body sodium, clinical presentation, and the treatment. So hypovolemic hypernatremia. Water loss is much greater than sodium loss. Renal causes that are renal are osmotic diuresis, diarrhea use, post-operative diuresis, and high output acute tubular necrosis. One more time, the causes of hypovolemic hypernatremia: renal, osmotic diuresis, diuretic use, post-operative diuresis, high output acute tubular necrosis. The effect on total body water, decrease. Effect on total body sodium, decrease. Clinical presentation, orthostasis, hypotension, tachycardia, dry mucous membranes. Treatment involves 0.9% NaCl until vital signs stable and free water replacement. So the euvolemic or isovolemic hypernatremia. Water loss only. Causes can be congenital or acquired diabetes insipidus, nephrogenic diabetes insipidus, or primary polydipsia. Effect on total body water, decrease. Effect on total body sodium, equilibrium. Depends on severity of hypernatremia. So our clinical presentation depends on severity of hypernatremia. It can present as seizures or lethargy. Treatment is free water replacement, arginine vasopressin, or an arginine vasopressin analog. So hypervolemic, hypernatremia. Sodium gain is greater than water gain. Causes can be sodium overload, example 3% sodium chloride, sodium bicarbonate, salt tablets, concentrate tube feedings, hypertonic dialysate, or sodium-containing medications. The effect on total body water increase, effect of sodium increase, peripheral and pulmonary edema. This is how hypernatremia presents. Peripheral and pulmonary edema, variable blood pressure. Treatment: free water replaced with loop diuretic. Require hemodialysis to remove volume. Hypovolemic hyponatremia. Renal, adrenal, GI, lung, skin. The loss of water and sodium. So water loss is greater than sodium loss. Results in hypovolemic hyponatremia. So it's referring to the extracellular fluid having a decrease in the volume of the extracellular fluid, hypovolemic. And hypernatremia is referring to a milliequivalent per liter sodium cation serum sodium cation concentration of 145 milliequivalents per liter. Euvolemic hypernatremia. DI, skin loss, estrogen excess, adverse drugs, and osmotic diuresis. Loss of free water, and you have the euvolemic hypernatremia, so greater than 145 milliequivalents per liter. Diabetes insipidus. These are a few select causes. Central, DI, familial, unreplaced insensible losses, hypodipsia, organic. Nephrogenic, familial, hypercalcemia, chronic, hypokalemia, kidney disease, drug-induced lithium most common, phoscarnet, clozapine, amphotericin B, lopavir, dimethylcycline, didanosine, and phosphamide. Hypervolemic hypernatremia. Sodium overload, neural low corticoid excess, gain of water and sodium gain is greater than water gain. Hypervolemic hypernatremia. Hypernatremia signs and symptoms: mild, moderate, and severe. Mild, lethargy, weakness, confusion, restlessness, irritability. Moderate, twitching. Severe, seizures, coma, death. Usually requires acute increase in sodium 160 milliequivalents per liter. Serum sodium is greater than 180 millimoles per liter. Associated with high mortality. Hypernatremia treatment goals and principles. Correct sodium to 145 to 150 milliequivalents per liter. Rapid correction of serum sodium can result in movement of excess water into brain cells, cerebral edema, seizures, neurologic damage, death. Normalize ECM volume, awesome. Hypovolemic hypernatremia. Treatment and monitoring. Treat initially with 0.9% NaCl until hemodynamically stable. Initial infusion rate adults equals 200 to 300 milliliters per hour or higher. Children equals 10 to 20 milliliters per kilogram per hour. Once intravascular volume is restored, 0.45% sodium chloride, dextrose 5% in water, or another hypotonic fluid can be used to correct the water deficit. Monitor serum sodium cation volume status every 2 to 3 hours during the first 24 hours. Adjust the hypotonic fluid infusion rate accordingly. So for euvolemic hypernatremia, central DI, treatment and monitoring, use AVP replacement therapy with desmopressin, ED-AVP, and AVP analog, and increases water reabsorption. May be given by mouth. IV subcutaneous SL IN. Change in bioavailability will change in route. PO has poor bioavailability. Intranasal, so iron is intranasal. For 10 micrograms intranasal once daily, titrate to 20 micrograms twice a day based on serum sodium cation concentration. Duration of action 7 to 9 hours. Adverse reactions: water retention, intoxication, hyponatremia, hypervolemia. Monitor serum sodium cation concentration at 24 hours and every 3 to 4 days during the initial dosage titration period, then every 2 to 4 months. Euvolemic hyponatremia, euvolemic hypernatremia, nephrogenic DI, and monitoring. So euvolemic hypernatremia is talked about. Central DI, you treat it with desmopressin and APP analog. You can be given PO, IN, IV, SQ, or SL. Adverse reactions include water retention, intoxication, hyponatremia, or hypervolemia. Monitor serum sodium cation concentration 24 hours and every 3 to 4 days during the initial dosage titration period, and then every 2 to 4 months. So euvolemic hyponatremia, nephrogenic DI, monitoring. Stop potential contributing drugs. Correct concomitant electrolyte disturbances. Administer hypotonic fluids. Indomethacin 50 milligrams oral 3 times daily. Potentiates AVP activity, so arginine vasopressin activity. Adjunctive therapy with medications having antidiuretic properties. Diabetes insipidus treatment options. You can use desmopressin acetate, central and nephrogenic DI, 5 to 20 micrograms intranasally every 12 to 24 hours. Chlorpropamide, central, 125 to 250 milligrams. Or you can just 125 to 250 milligrams orally daily. Carbamazepine essential 100 to 300 milligrams orally twice daily. Glufobrate essential 500 milligrams orally 4 times daily. Hydrochlorothiazide essential and nephrogenic 25 milligrams orally every 12 to 24 hours. Amiloride nephrogenic 50 to milligrams orally daily. 10 milligrams orally daily. Amiloride lithium-related nephrogenic 5 to 10 milligrams orally daily. Indomethacin central and nephrogenic 50 milligrams orally every 8 to 12 hours. Hypovolemic hyponatremia. Hypovolemic hypernatremia. Hypervolemic hypernatremia. Treatment and monitoring. Administration of D5W plus diuretic to facilitate excretion of excess sodium cation. Furosemide 20 to 40 milligrams IV every 6 hours. Continue until signs of reach falling overload, pulmonary congestion, edema, resolve. Monitoring serum cation initially every 3 to 4 hours, then every 6 to 12 hours. Sodium concentration is less than 140 milliequivalents per liter. Results of potassium balance, hypokalemia and hyperkalemia. Okay, so potassium. Normal serum concentration range for potassium is 3.5 to 5 milliequivalents per liter. It's a major intracellular cation. Sodium, potassium, adenosine triphosphate. Pump in the cell membrane contains intracellular stores of potassium. Transport sodium out of the cell, potassium into the cell, a ratio of 3. Correction. Transport sodium out of the cell and potassium into the cell at a ratio of 3 to 2. Transport sodium out of the cell and potassium into the cell at a ratio of 3 to 2. Okay, potassium homeostasis, dietary intake, GI and urinary excretion, hormones, insulin, aldosterone, catechol, amines, and acid-base balance. Potassium homeostasis, dietary intake on GI and urinary excretion. Dietary intake abundant in fruits, vegetables, meat, whole grains, and milk products. Most dietary potassium is absorbed with only 10 to 20 milliequivalents per day, limited in feces. GI and urinary excretion. Kidney is the primary route of potassium elimination. Potassium is freely filtered, almost all of it is reabsorbed, possibly the proximal tubule and the thick ascending loop of Henle. Potassium homeostasis, the hormones. Insulin, most important hormone mediator, stimulates the cellular sodium-potassium ATPase pump, thereby intracellularly shifting potassium. Tightly regulates serum potassium via a complex negative feedback loop. Serum potassium increases the pancreatic insulin secretion to prevent hyperkalemia. Aldosterone, secreted from the adrenal glands in response to high serum potassium concentrations, promotes urinary potassium excretion. Catecholamines, usually epinephrine, result in intracellular movement of potassium by two mechanisms. Stimulation of beta receptors, which directly activates the sodium potassium ATPase pump. Glycogenolysis, which raises blood glucose concentration, thereby increasing insulin secretion. So, potassium homeostasis, acid-base balance. Metabolic acidosis that results from increased serum metabolic acidosis, increased serum protons, or increased serum potassium cations. So increased hydrogen cations or increased hydrogen cations leading to increased serum potassium cations, which is going to be hyperkalemia, false hyperkalemia, not true excess of total body potassium. Metabolic alkalosis associated with hypokalemia, false hypokalemia, not true deficiency in total body potassium. Hypokalemia. Potassium is less than 3.5 milliequivalents per liter. Mild hypokalemia 3.1 to 3.5. Moderate hypokalemia 2.5 to 3. Severe hypokalemia less than 2.5. Mild hypokalemia 3.1 to 3.5 milliequivalents per liter. Moderate hypokalemia 2.5 to 3 milliequivalents per liter. Severe hypokalemia less than 2.5 milliequivalents per liter. Commonly encountered electrolyte abnormality in clinical practice. As many as 20% of hospitalized patients will develop hypokalemia. Workup should include comorbid disease states and medication history for non-existent healthy adults. So hypokalemia, total body potassium deficit, poor dietary intake, renal or GI loss. Intracellular shifting, metabolic alkalosis, medications, variety of mechanisms, including transcellular potassium shifting and enhanced renal or stool losses, common drugs, diuretics. Hypomagnesemia, present in 50% of patients with clinically significant hypokalemia, reduces the intracellular potassium concentration and promotes renal potassium waste. Magnesium. Okay, drug-induced hypokalemia, transcellular shift, the beta receptor agonist, epinephrine, albuterol, tibulate, motorol, zimalerol, isoproterenol, ephedrine, cidofedrine, glucolytic agents, ritodrine, alidrine, also theophylline, levothyroxine, decongestant, caffeine, insulin, verapamil, and barium overdose. So, enhanced renal elimination, diuretics, acetazolamide, thiazides, metabolism, furosemide, porcimide, metamide, bumetanide, anticrinic acid, high-dose penicillin, mineralocorticoids, miscellaneous aminoglycosides, amphotericin, flat, non-fecal elimination, laxatives, sodium polystyrene, sodium sulfone, phenolphthalein, sorbitol, pyramide, sodium zirconium cyclosilicate, hypokalemia, signs and symptoms, mild, usually asymptomatic, moderate cramping, weakness, malaise, myalgia, severe EKG changes, electric arrhythmias, heart block, atrial flutter, ventricular fibrillation, cramping and impaired muscle contracting, can cause death from respiratory paralysis. Hypokalemia, treatment goals, prevent and or treat serious life-threatening complications, normalize serum concentration, identify and correct underlying cause, prevent overcorrection of serum potassium. So if you have 3.5 to 4 milliequivalents per liter, this is mild hypokalemia. Encourage dietary intake of potassium-rich food, no pharmacological therapy. So moderate hypokalemia, 3 to 3.4 milliequivalents per liter, non-pharmacological therapy in asymptomatic patients, oral potassium supplement in patients with conditions predisposing them to arrhythmia. Now, severe hypokalemia, less than 3 milliequivalents per liter, should always be treated to achieve levels of 4 to 4.5 milliequivalents per liter. Give oral potassium supplement to patients asymptomatic. Give IV potassium if patient is symptomatic presenting with severe depletion of potassium less than 2.5 milliequivalents per liter, or cannot tolerate oral therapy. Clinical pearls. Account for renal function when depleting potassium. Reduce potassium in patients with renal impairment / renal failure. Many institutions utilize potassium replacement protocol in ICU. Carefully review the patient's MAR to account for all potassium doses received by the patient. Supplemental potassium is a common cause of hypokalemia in hospitalized patients. Treat hypomagnesemia first. So hypokalemia non-pharmacological treatment. Things with high content potassium: kidney beans, lentils, soybeans, lima beans, pinto beans. Get your fishes: halibut, Pacific rockfish, Pacific cod, yellowfin, tuna, rainbow trout, or cooked. You have upgraded milk, non-fat, low-fat, reduced fat, chocolate milk, skim milk, low-fat milk, buttermilk, orange juice, fresh, bananas, peaches, prunes, apricots, plantains, tomato sauce, pork. Very high content: potato, canned juice, prunes, carrots, tomato paste, tomato puree, beet, greens, white beans, plain yogurt, plums. Oral potassium, generally well absorbed. Take with food, and then crush, chew, or cut, then release tablet. Reverse effects, GI related. Potassium salts, potassium bicarbonate, concurrent conditions preferred, metabolic acidosis. Potassium phosphate, neutrophosphamine, hypophosphatemia. So we're talking about potassium salts and the concurrent conditions preferred. So if you're given potassium bicarbonate, otherwise known as K-Vescent, concurrent conditions preferred, metabolic acidosis. Potassium phosphate, neutrophosphamine, concurrent conditions preferred, hypophosphatemia. Potassium chloride, K-diarrhea, K, most common for diuretic and diarrhea-induced hypokalemia. Most common causes of potassium depletion. Both conditions are associated with chloride losses. IV potassium, more dangerous than oral, so for this hypokalemia, pain on injection site. Choose the right vehicle. Always prepare with saline solution, 0.9% or 0.45 NaCl. Don't use dextrose solutions to stimulate insulin release and cause hypokalemia. Endocrine equivalent potassium in 100 ml sodium chloride, safe when infused to peripheral IV over 1 to 2 hours. KT monitoring and infusion rates with 10 milliequivalents per hour. JB is a 60-year-old man hospitalized with COPD exacerbation. His labs revealed a serum potassium concentration of 2.1. So we know that 3.5 to 4 is mild, 3 to 3.4 is moderate, and less than 3 is severe. So he has severe hypovolemia. He is complaining of muscle pain, which is following the most frequent treatment for JB. Potassium chloride IV piggyback. It is recommended to divide the total daily dose of oral potassium supplements into smaller doses to help minimize which of the following adverse effects. GI upset. So hyperkalemia. Potassium is greater than 5 milliequivalents per liter. Mild hyperkalemia, 5.1 to 5.9 milliequivalents per liter. Moderate hyperkalemia, 6 to 7 milliequivalents per liter. Severe hyperkalemia, greater than 7 milliequivalents per liter. Many cases in hospitalized patients are the result of overcorrection of hyperkalemia with IV potassium. Occurs more commonly in elderly patients with impaired renal function, including chronic by mouth supplementation, chronic oral supplementation. Hyperkalemia, etiology and pathophysiology. Increased intake of food supplements or salt substitutes. Generally stage 4 or 5 chronic kidney disease, dialysis patients, non-compliant with dietary potassium restriction. Decreased excretion. Kidneys excrete 9% of daily potassium intake. Endocrinologic disorders, including adrenal insufficiency, Addison disease, selective hypoaldosteronism. Less or decreased aldosterone production leads to potassium retention. Drug-induced, typically dose-dependent. Tubular unresponsiveness to aldosterone. Anemia, systemic lupus erythematosus, SLE, amyloidosis. Defect in renal tubular potassium secretion. Distribution of potassium into the extracellular space. Efflux of potassium from within the cell into the ECM. No change in total body potassium. Metabolic acidosis, cellular damage, rhabdomyolysis, trauma, burns, tumor lysis syndrome. So drug-induced hyperkalemia. Drug classes: ACEs, ACE inhibitors, benzopyrrole, captopril, enalapril, lisinopril. So CELB, captopril, enalapril, lisinopril, benzopyrrole. So your ARBs: candesartan, irbesartan, olmesartan, losartan, valsartan. So VIOCL, valsartan, irbesartan, olmesartan, candesartan, losartan. Direct binding inhibitors: aliskiren, fast-sparing diuretics, amiloride, pyranose, spironolactone, triamcinolone. Prostaglandin inhibitors, the NSAIDs, miscellaneous plasma salts, example penicillin G, digoxin, cyclosporin, tacrolimus, permethoprim, sulfamethoxazole, heparin. So hyperkalemia signs and symptoms: frequently asymptomatic, heart palpitation, skipped beats, muscle weakness, bradycardia. Utility changes: peak T waves, widening PR interval, loss of P wave, widening PRS complex, ventricular tachycardia. Antagonize adverse cardiac effects. Is hyperkalemia treatment goals. Reverse signs and symptoms are present. Return the serum and total body stores of potassium to normal. So you want to antagonize adverse cardiac effects. When reverse signs and symptoms are present, you want to return the serum and total body stores of potassium to normal. Hyperkalemia treatment recommendations. Treatment depends on the severity of hyperkalemia, the rapidity of its development, and the patient's clinical condition. Asymptomatic to mild, 5.1 to 5.9 milliequivalents per liter, usually requires dietary modification and daily monitoring for inpatient and weekly for outpatient. Moderate 6.9 as well as grade 7. Hyperkalemia, accompanied by clinical symptoms or EKG changes, requires immediate treatment. So hyperkalemia treatment recommendations. So for severe hyperkalemia, greater than 7 milliequivalents, or moderate 6.9 milliequivalent hyperkalemia. Antagonism of the cardiac membrane action of hyperkalemia, you can use IV calcium gluconate or IV calcium chloride. Decrease extracellular potassium, promoting its intracellular movement. Use insulin glucose beta-2 agonists and sodium bicarbonate. For potassium excretion from the body, you can use through dialysis, diuretics, or oral administration of cation exchange resins. Step 1. Stabilization of cardiac action potential. IV calcium gluconate or IV calcium chloride stabilizes the myocardium, does not decrease potassium level, dosing regimen, 1 gram IV bolus administered over 5 to 10 minutes. Calcium chloride contains 3 times more calcium per gram than calcium gluconate, more effective. Calcium chloride can cause tissue necrosis if extravasation occurs. Hence, calcium gluconate is more commonly administered. Calcium chloride can cause tissue necrosis if extravasation occurs. Hence, calcium gluconate is more commonly administered. Repeat every 10 to 30 minutes is needed. So, step 2, shifting potassium from extracellular to intracellular. You can use IV regular insulin, 5 to 10 units regular insulin, duration 2 to 6 hours. Give IV dextrose for e.g. less than 250 milligrams per dl. Sodium bicarbonate, useful in metabolic acidosis. 50 to 100 milliequivalents IV over 2 to 5 minutes. Raises serum pH and shifts potassium to ICS. Beta-2 agonists stimulate sodium potassium ATPase pump to promote intracellular potassium uptake and stimulate pancreatic beta receptors to increase insulin secretion. 10 to 20 nebulized over 10 minutes. Increasing potassium excretion. The dialysis, most rapid methods of lowering potassium levels, removal of potassium, loop diuretic, using normal renal function of stage 3 or 4 CKD, promotes urinary potassium excretion, furosemide 20 to 40 milligrams IV every 4 to 6 hours. Exchange resin, sodium polystyrene sulfonate, K-exylene, 15 to 60 grams per mouth or PR every 4 hours. As needed. The mouth is more effective than the enema and is better tolerated by patients. Each gram of sodium polystyrene sulfonate exchanges 1 milliequivalent of sodium for 1 milliequivalent of potassium in the intestines. Contains a significant amount of sodium. Caution in heart or renal failure due to sodium retention. Separate from other oral medications by at least 3 hours, as it may bind to and increase the effectiveness of many oral medications. Contraindications include obstructive bowel disease. Hemodialysis is the main interval onset duration of action when it comes to treating hyperkalemia. It can be followed by furosemide, calcium, so several options. Be ranked as such: hemodialysis, furosemide, calcium, insulin, dextrose, sodium bicarbonate, albuterol, albuterol, sodium zirconium cyclosilicate, and patiromer. Okay, patient presents to the emergency department with a potassium level of 8 milligrams per liter, so that's severe hyperkalemia. Study EKG reduces peak waves and wide PR interval. Which of the following is the immediate first-line treatment for this patient? Administer calcium gluconate 1 gram IV bolus over 5 days. Which of the following therapies does not increase potassium excretion? Calcium gluconate. Calcium gluconate is going to be used to stabilization of cardiac action potential. Insulin, bicarb, beta-2 agonists can be used to shift potassium from AC to IC. They increase the excretion of potassium, dialysis diuretic, and SPS resin. Polystyrene sulfonate. Okay, so magnesium function homeostasis. Normal serum range 1.4 to 1.8 equivalents per liter. It's a major intracellular cation. Function is important. It's an important cofactor in over 300 biochemical reactions in the body, especially with ATP. It plays an important role in cellular functions, mitochondrial function, protein synthesis, cell membrane function, glucose metabolism, and parathyroid hormone secretion. Required for activity of the sodium-potassium ATPase pump. Homeostasis depends on the balance between intake and output. Hypomagnesemia. Etiology. Magnesium is less than 1.4 milliequivalents per liter. Common in ambulatory and hospitalized patients. Up to 65% of ICU and 20% of general medical patients have magnesium deficiency. Usually associated with the drugs or conditions that interfere with intestinal absorption or increase renal excretion of magnesium. Causes of hypomagnesemia. TI. So you have reduced intake, protein calorie malnutrition, prolonged parenteral fluid administration without magnesium, and also alcoholism. Reduced absorption. Primary hypomagnesemia. Malabsorption syndromes, short bowel syndrome, pancreatic insufficiency, proton pump inhibitors, long-term use. Increased loss. Excessive vomiting, prolonged nasogastric suction, excessive laxative use, intestinal and biliary fistulas, prolonged diarrhea. Causes of hypomagnesemia. Renal. Primary tubular disorders, drug-induced renal losses, hormone-induced renal losses. So we have primary tubular disorders, we have primary renal magnesium wasting, Bartter syndrome, renal tubular acidosis, diuretic phase of acute tubular necrosis, post-obstructive diuresis, post-renal transplant diuresis, drug-induced renal losses, aminoglycosides, amphotericin B, cyclosporine, tacrolimus, diuretics, digitalis, pentamidine, and foscarnet. Hormone-induced renal losses, primary hyperparathyroidism, aldosteronism, Hunter-Bone syndrome of the parathyroid gland. So causes of hypomagnesemia, internal redistribution and other. Internal redistribution, diabetic ketoacidosis, other excessive swelling and lactation. Internal redistribution, pediatric glucose aminoacid insulin administration. Other hypercalcemia and hypercalciuria. Internal redistribution, massive blood transfusion, rapid citrate. Other phosphate depletion, memory distribution, pancreatitis, lipedema. Other chronic alcoholism, ECL form expansion. Hypomagnesemia signs and symptoms. Neuromuscular, twitching, technique, generalized convulsion. Cardiovascular, heart palpitations. Hypertension, arrhythmias, ventricular fibrillation, suicidal points, ECG abnormalities, sudden cardiac death. One more time, cardiovascular, heart palpitations, hypertension, arrhythmias, ECG abnormalities, and sudden cardiac death. Electrolyte disturbances, hypokalemia, hypocalcemia. Hypomagnesemia, treatment goals, resolution of signs and symptoms, restore normal magnesium levels, correct concomitant electrolyte abnormalities, identify and correct underlying causes of magnesium depletion. Hypomagnesemia treatment. Magnesium supplementation can be given by mouth, intramuscular, or intravenous routes. By mouth is preferred. IM administration is painful, reserved for severe hypomagnesemia and limited IV access, and or IV bolus administration causes hypotension, flushing, and swelling. Administer slowly by infusion. There's no optimal regimen for replacement. Typically 8 to 12 grams total of magnesium sulfate, divided doses in the first 24 hours, followed by 4 to 6 grams per day for 3 to 5 days. Thereafter to repeat body stores. 50% of administered doses are excreted in urine. Multiple mg doses, severe days, 35 days may be necessary. Hypomagnesemia treatment continues. So 1 to 4 milliequivalents to 1 milliequivalent per liter. Oral supplementation preferred. Common adverse effect, diarrhea. Less than 1 milliequivalent per liter or if signs and symptoms are present, regardless of serum magnesium. Magnesium sulfate, IV, administer 4 to 6 grams in 50 to 100 milliliters in divided doses over 12 to 24 hours. Repeat as necessary to maintain concentration of 1 milligrams per liter. Typical dose 2 to 4 grams and 50 ml over 1 hour. You usually have to repeat for adequate repletion. Extensive renal excretion. Reduced dose by 25% to 50% in patients with impaired renal function. Adverse reactions, hypotension, flushing, swelling, and vasodilation. Common oral magnesium products. Magnesium oxide, 242 milligrams in 400 milligram tablet. Magnesium hydroxide, 167 milligrams in 400 milligram tablet or 5 ml oral suspension. Magnesium chloride, 64 milligrams in each 535 milligram tablet. Magnesium citrate, 48 milligrams in each 5 milliliters of the oral solution. Magnesium gluconate, 27 milligrams in 500 milligram tablet. Magnesium lactate, 84 milligrams in 84 milligram tablet. So hypermagnesemia, greater than 1.8 milliequivalent per liter, occurs primarily in settings of renal insufficiency, CKD stage 4 or 5. Must increase magnesium intake, usually from vitamins. Magnesium excretion decreases as filtration rate declines. Causes of hypermagnesemia. Decreased renal excretion, so acute renal failure or CKD with excessive intake. Treatment of eclampsia and pregnancy. Urethral irritants. Acid. Cathartics. Other lithium therapy. Hypothyroidism. Milk alkali syndrome. Asthma disease. Acute diabetic ketoacidosis. Hypermagnesemia signs and symptoms. Neuromuscular, lethargy, sedation, confusion, muscular weakness, paralysis, respiratory depression, cardiac dysrhythmias, hypertension, continuous vasodilation, heart block, and bradycardia. Hypermagnesemia treatment goals: reverse neuromuscular and cardiovascular complications, decrease magnesium concentration to avoid normal values, identify and treat the underlying cause. Hypermagnesemia treatment mechanisms: reduce magnesium intake, enhance elimination, and antagonize the physiological effects of magnesium. To enhance elimination, force diuresis with 0.45 normal saline, and loop diuretics to promote magnesium elimination. I.e. furosemide 40 milligrams IV. Reduces serum magnesium within 12 hours. Hemodialysis corrects hypermagnesemia within 4 hours. Reasonable option for patients who are already on hemodialysis. 3. Antagonize the physiological effects of magnesium. Calcium IV 100 milligrams to 200 milligrams elemental. Antagonizes neuromuscular and cardiovascular effects. 1 gram to 2 grams calcium gluconate IV. Transient effect, repeated doses may be needed hourly until the signs and symptoms improve and magnesium is normalized. Does not lower magnesium level. Dose of calcium bar. Hypocalcemia, hypercalcemia. Normal serum range for calcium 8.6 to 10.2 milligrams per deciliter. Ionized brackets freeze unbound calcium 4.5 to 5.2 milligrams per deciliter. Skeletal bone contains greater than 99% of total body calcium. Skeletal bone contains greater than 99% of total body calcium. ECF calcium is markedly bound to plasma protein 5%. Calcium regulation and homeostasis is important to function of cell membranes, propagation of neuromuscular activity, regulation of endocrine and secondary functions, blood coagulation cascade, platelet adhesion process, bone metabolism, muscle cell excitation, contraction, coupling, mediation of electrophysiologic slow channel response, and cardiac response. Calcium regulation and homeostasis. Ionized calcium concentration is closely regulated by the injections of parathyroid hormone, phosphorus, vitamin D, and calcitonin. PTH increases serum calcium concentrations by stimulating calcium release from bone, increasing renal tubular reabsorption, enhancing absorption in the GI tract secondary to increased kidney production of 1,2,5-dihydroxyvitamin. Vitamin D directly increases serum calcium as well as phosphorus concentrations by increasing GI absorption. Indirectly, it can also lead to calcium release from the bone and reduce renal excretion. Calcitonin inhibits osteoclastic bone resorption. Calcitonin plasma concentrations are increased when ionized calcium concentrations are high, as the body attempts to return the serum calcium concentration to the range. Assessment of total serum calcium requires measuring serum albumin. Corrected serum calcium equals measured serum calcium in milligrams per deciliter plus 0.8 times, in brackets, 4 minus measured albumin. So measured serum calcium plus, in brackets, 0.8 times 4 minus measured albumin, in brackets. So hypocalcemia, less than 8.6 milligrams per deciliter, occurs infrequently in outpatient settings, occurs frequently in adult hospitalized patients, most common in elderly, malnourished, and patients receiving sodium phosphate bowel prep. Result of alterations in the effect of PTH and vitamin D on the bone and kidney. Primary causes of vitamin D deficiency and postoperative hypoparathyroidism. Other causes include critical illness, medications, hypoalbuminemia, blood transfusions, peripheral blood progenitor cell harvesting, hypocalcemia causes. Nutritional vitamin D deficiency is the most common cause of chronic hypocalcemia worldwide, less common in Western societies. Vitamin D is necessary for the optimal absorption. Vitamin D is necessary for the optimal absorption of calcium and phosphorus. It can occur secondary to chronic kidney disease if there is insufficient production of the 1-alpha hydroxylase enzyme, produced the 1,2,5-dihydroxyvitamin D3. Hypocalcemia causes. Surgery is the most common cause of chronic hypoparathyroidism. It can be caused by autoimmune disease, congenital defects, or iatrogenically. Thyroidectomy, radiation therapy damage. Chronic hypoparathyroidism persisting for more than 6 months may lead to hypocalcemia. Chronic hypocalcemia may ultimately present visual impairment secondary to cataracts. Hypocalcemia causes hungry bone syndrome. Profound hypocalcemia, where bone rapidly incorporates calcium and phosphorus from the blood in an attempt to recalcify bone. Acute symptomatic fall in total serum calcium concentration to less than 7 milligrams per deciliter. Common in patients with a recent parathyroidectomy or thyroidectomy. Hypocalcemia causes hypomagnesemia. Hypomagnesemia of any cause can be associated with severe symptomatic hypocalcemia as unresponsive to calcium replacement therapy. Reduced serum magnesium concentrations can impair PTH secretion and induce resistance of target organs to the actions of PTH. Normalization of serum calcium concentrations in these patients is dependent on appropriate magnesium replacement. Hypocalcemia causes during critical illness or post-operatively. Hypocalcemia is common but usually mild. Hypothesized that cytokines impair PTH secretion, decrease production of 1,2,5-dihydroxyvitamin D3, and cause PTH resistance. Hypocalcemia causes drug-induced furosemide, calcitonin, bisphosphonates, oral phosphorus therapy, dosima, peg bowel prep, phenobarbital, phenytoin, cincalcet, fluoride, ketoconazole, hamidine, and drugs that cause hypomagnesemia are also associated with the risk of hypocalcemia. So hypocalcemia signs and symptoms: you got your neuromuscular tetany, EP, extrapyramidal disorders, paresthesia, muscle cramps, laryngeal spasm. Also CNS depression, anxiety, memory loss, confusion, hair loss, groove, brittle nails, eczema, EKG change, prolonged QT interval, arrhythmia, bradycardia, hypertension, unresponsive to fluid, vasopressor administration. Hypocalcemia treatment rules: resolution of signs, symptoms, restore normal serum calcium levels, correct concomitant electrolyte abnormalities, identify and treat the underlying cause. For acute hypocalcemia, use IV calcium 1 gram to 3 grams over 10 to 30 minutes. That could be calcium chloride 1 gram IV, 37% elemental calcium to prevent tissue necrosis, administered via central venous access. Use calcium gluconate 2 to 3 grams, 9% elemental calcium, preferred for peripheral venous administration, less irritating to veins. Infused naproxen 6 milligrams per minute. EKG monitoring recommended. Evaluate ionized calcium 10 to 12 hours after IV. Therapy: symptom for severe asymptomatic hypocalcemia. Adverse effects: bradycardia, AV block, hypertension. Viability: add bicarbonate and phosphorus preparation. Chronic oral calcium and vitamin D supplementation. Starting dose 1 to 3 grams per day, elemental calcium. Average maintenance dose 2 to 8 grams per day, elemental calcium divided doses. Adverse effects: hypercalcemia, hypocalciuria. Oral calcium and vitamin D preps. Drug calcium carbonate 40% elemental calcium. Meals: calcium citrate may take without regard to meal. Vitamin D3, adequate daily intake, 400 to 800 units per day, varies by age to achieve adequate intake. OTC, 2 capsule solution, prescription only. Hypercalcemia, etiology and epidemiology. Calcium greater than 10.2 milligrams per deciliter. Multiple causes of hypercalcemia, most commonly caused by cancer and hyperparathyroidism. Primary hyperparathyroidism occurs predominantly after age 50, affects women 3 to 4 times more than men. Accounts for the majority of cases in the outpatient setting. Cancer-associated hypercalcemia occurs in approximately 10 to 30% of patients with cancer at some time during the course of the disease, and is dependent on tumor type, predominantly occurring in hospitalized patients. Hypercalcemia causes: you can have neoplasms, bone metastasis, neural induced, medications, thiazides, lithium, vitamin D or vitamin A, calcium, aluminum, magnesium, acid, antacids, calcium, aluminum, magnesium, antacids, theophylline, tamoxifen, gancyclovir, granulomatous disease, sarcoidosis, tuberculosis, cryptococcus, borreliosis, histoplasmosis, coccidioidomycosis, leprosy, endocrine disease, adrenal insufficiency, hyperthyroidism, acromegaly, hyperparathyroidism, primary, tertiary, miscellaneous, mobilization, Parkinson's disease, familial hypocalciuric hypercalcemia, adolescents and adolescents. Hypercalcemia, increased bone resorption, increased GI absorption, or increased tubular resorption by the kidneys. Mild to moderate hypercalcemia, greater than 10.5, but less than 13, often asymptomatic. Severe hypercalcemia, greater than 13. Signs and symptoms involve anorexia, nausea, vomiting, constipation, polyuria, so peeing a lot, polydipsia, drinking a lot, nocturia. Hypercalcemic crisis, greater than 15 minutes later. Acute renal injury, obtundation, arrhythmia. If untreated, may progress to renal failure, coma, life-threatening ventricular arrhythmia. Chronic hypercalcemia, mastite calcification, hypercalciuria, chronic renal. Hypercalcemia treatment goals: reverse signs and symptoms, restore normal calcemia within hours to days, depending on severity, and correct or manage underlying cause of hypercalcemia. For acute, induced by malignancy, may be treated with chemotherapy, radiation, surgical or drug treatment of primary hyperparathyroidism. Hypercalcemic crisis, acute symptomatic severe hypercalcemia are considered medical emergencies requiring immediate treatment. Chronic, usually caused by underlying medical condition or prescribed medication, may be resolved by treating underlying condition or withdrawing offending agent. The treatment options you can use normal saline, monitoring and special population considerations, natural abnormalities, food overload, insufficiency, and congestive heart failure. Okay, starting dose 200 ml and time frame to initial response 24 to 48. You can also use calcitonin, myacalcin, 4 units. Monitoring and special population considerations involve phases of flushing, nausea, vomiting, allergic reactions, CI, in a patient with allergy to calcitonin. Palmidronate or Aridia, zoldronate, corticoids, or diuretics. Calcitonin, myacalcin. Mechanism of action: decreases calcium by inhibiting bone absorption. Used in patients where saline hydration is contraindicated, for example, congestive heart failure, might lead to severely impaired renal function. Short-term therapy to reduce calcium within 24 to 48 hours. Effect can be transient. IV, cut 40 units per kilogram every 12 hours. Adverse effects: allergic reactions, flushing, nausea, vomiting, tachyphylaxis. So bisphosphonate, mechanism of action: block bone resorption, inhibit osteoclasts. First line for hypercalcemia of malignancy: palmidronate and zoledrone acid. Slower onset of serum calcium concentration decline. Concentration begins to decline in 2 days and reach nadir in 7 days. Calcitonin therapy or other interventions may be necessary if more rapid serum calcium production is needed. Dosing palmitonate, Iridia, 90 milligrams, IV infusion, administered over 24 hours. Zoledronic acid, class 48 milligrams, IV administered over 15 minutes. Bisphosphonates, adverse effects: fever, common, fatigue, osteonecrosis of the jaw. Zoledronic acid has been associated with atrial fibrillation. Monitoring, you want to check your renal function. Therapy. Nosumab, Tego. Mechanism of action: monoclonal antibody inhibits the receptor. Activator of nuclear factor kappa light chain enhancer of activated T cells. Again, RANK. L frequency mediator of osteopath survival. FDA approved for the treatment of hypercalcemia of malignancy refractory to IV bisphosphonate therapy. Corrected serum calcium remains greater than 12.5 milligrams per deciliter after more than 7 days of therapy. Dosing: 120 milligrams subcut every 4 weeks. Adverse effects: osteonecrosis of the jaw and hypocalcemia. Monitoring serum calcium in patients with reactant clearance less than 30 ml per minute. So corticosteroids reduce GI calcium absorption. Effective in treatment of hypercalcemia resulting from multiple myeloma, leukemia, lymphoma, sarcoidosis, hypervitaminosis A and D. They also prevent tachyphylaxis with calcitonin. Usual dose: prednisone or equivalent agent, 40 milligrams to 60 milligrams daily. Advantages: relatively slow onset of action, and the potential for diabetes mellitus, osteoporosis, and increased susceptibility to infection. Calcinometic agent: calcin, sensipar. Mechanism of action: increases the sensitivity of the calcium sensing receptor on the parathyroid gland, resulting in reduced PTH and serum calcium. So dosing 30 milligrams per ml twice a day. Treated every 2 to 4 weeks in 30 milligram increments until the desired serum calcium concentration is achieved. Maximum approved dose: 90 milligrams 3 times a day or 4 times a day. Adverse effects: hypocalcemia. Adverse effect: hypocalcemia. Disorders of phosphorus balance: hypophosphatemia and hyperphosphatemia. Normal serum range in adults: 2.7 to 4.5 milligrams per deciliter. Major intracellular anion: 85% of body stores found in bone. Typical Western diet provides a daily intake of 800 to 1,600 milligrams of phosphorus. 60% to 80% of oral intake is absorbed in the GI tract. Hypophosphatemia: phosphate less than 2.7 milligrams per deciliter. Mild to moderate: 1.5 to 2.7 milligrams per deciliter. Usually asymptomatic. Severe: less than 1.5 milligrams per deciliter. Observed in 1.1 to 3% of patients admitted to the hospital. Incidence in critically ill patients is 18 to 28%. Hypophosphatemia, pathophys: decreased GI absorption, reduced tubular reabsorption, or extracellular to intracellular redistribution. So conditions associated with hypophosphatemia develop: decreased GI absorption, phosphate binding drugs, sucralfate, calcium carbonate, aluminum / magnesium acids, sevelamer, lanthanum carbonate, decreased dietary phosphorus intake, coilocoids, vitamin D deficiency resistance, hypoparathyroidism, chronic diarrhea, steatorrhea, reduced tubular reabsorption, hyperparathyroidism, primary and secondary, elevated FGF23, recovery from burns, rickets, malignant neoplasms, Fanconi syndrome, acute volume expansion, metabolic acidosis, renal transplantation, vitamin D deficiency, and resistance. Diuretics, loop diuretics, thiazide diuretic, acetazolamide, noic agents, glucocorticoids, sodium bicarbonate. Internal redistribution, feeding syndrome, parenteral nutrition, parathyroidectomy, hungry bone syndrome. Alcoholism, respiratory alkalosis, diabetic ketoacidosis correction, dextrose solutions, insulin, catecholamines, anabolic steroids, glucagon, calcitonin, erythropoietin. Hypophosphatemia signs and symptoms. Mild to moderate hypophosphatemia, usually asymptomatic. Severe hypophosphatemia, neurologic, anabolic encephalopathy, seizures, coma, cardiopulmonary, impaired myocardial contractility, respiratory failure, or congestive heart failure. Musculoskeletal, myalgia, bone pain, weakness, rhabdomyolysis, hematology, hemolysis, thrombocytopenia. Hypophosphatemia treatment goals: reverse signs and symptoms, normalize serum phosphorus concentrations, manage underlying conditions. Hypophosphatemia treatment approach. The acuity and other electrolyte conditions dictate the salt formulation and route of administration of phosphorus supplementation. Mild to moderate hypophosphatemia, 1.5 to 2.7 milligrams per deciliter, can be treated with oral phosphate salts. Osmotic diarrhea is a primary dose-limiting adverse effect. IV phosphorus supplementation is patients who are unable to receive oral supplements. Severe less than 1.5 milligrams per deciliter of symptomatic hypophosphatemia, IV phosphorus supplementation. Mild hypophosphatemia, 2.3 to 2.7 milligrams per deciliter. If unable to receive oral supplementation, IV phosphorus we're talking about. Dose 0.08 to 0.1 millimoles per kilogram. Moderate hypophosphatemia, 1.5 to 2.2 milligrams per deciliter. If they can't receive oral supplementation, dose 0.16 to 0.32 millimoles per kilogram. Patient with impaired kidney function to receive reduced doses, typically less than or equal to 50% of the initial empiric dose. Carefully monitor serum phosphate due to predisposition to phosphate retention. Severe less than 1.5 mg per deciliter or symptomatic hypophosphatemia. Dose 0.32 to 0.64 millimoles per kilogram. Normal renal function. Dosage and infusion recommendation as well as response to IV phosphate replacement are highly variable. CB is a 54-year-old female presented to the emergency department hospital with respiratory distress and weakness. The lab reveals potassium 5.8, sodium 139, magnesium 1.9, phosphate 1.4, serum creatinine 1. The following is the best treatment for CB's hypophosphatemia. Sodium phosphate IV. So maximum rate of infusion for IV phosphorus 7.5 millimoles per hour. If potassium or sodium salts for IV phosphorus based on the other electrolyte values. Concomitant hypokalemia, choose potassium phosphate. 1 millimole potassium phosphate equals 1.47 potassium. If potassium is greater than 4, choose sodium phosphate, 1 millimole sodium phosphate. Hyperphosphatemia. Phosphate greater than 4.5 milligrams per deciliter. Margin severe greater than 6.5 milligrams per deciliter. Severe greater than 7. Most common causes CKD, so chronic kidney disease, or acute kidney injury, or intracellular phosphate release. Tumor lysis syndrome, complication of chemotherapy. Massive lysis of cells and release of intracellular contents. Pathophys for hypophosphatemia. Reduced renal tubular resorption of phosphate, excessive exogenous phosphate loads, tissue catabolism, rhabdomyolysis, and acid base disorders. Signs and symptoms of hypophosphatemia: acute GI disturbances, the obstruction of the urinary tract, and rarely seizures, chronic red eye and pruritus or itchy skin. Signs: elevated calcium phosphate product results in precipitation in arteries, joints, soft tissues, and the viscera. can result in tissue necrosis, calciphylaxis, or calcium uremic arterial hyperphosphatemia. Avoid GI and neurologic symptoms. Prevent disease deposition in urinary tract. Return serum phosphate concentration to normal 1 nano. Hyperphosphatemia treatment. Spare symptomatic, manifesting with hypocalcemia and tetany, calcium, non-emergent phosphate binding therapy. Divalent and trivalent cations containing calcium, lanthanum, magnesium, iron, aluminum. Valamer, administered 2 times a day with meals. Avoid long-term treatment with aluminum hydroxide and aluminum carbonate, as they have been associated with anemia, CNS disorders, and bone disease. That's the end.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Thanks for listening to the podcast series The New Student Pharmacist, where we discuss chemistry and pharmacy, as well as leaders in pharmacy careers, community, and chemistry and pharmacy research. We encourage you to support the work we are doing and follow us on Spotify and Apple Podcasts by subscribing for free. We are so glad that you were able to tune in today. Note, the views on the podcast represent those of my guests, and I take care and all the best.